Hi guys. Okay, this is a new way to be able to communicate information to you because sometimes I just can't cover it all in the meetings, and some of these topics are things that I would rather you have some reference to go back to and have some just information at your fingertips about some of the topics that I touch base on in the meetings. And so this first video is just going to be kind of just a trial to just see how easy it is for you guys to listen to these videos, and also just if it's a helpful way to communicate. So this one is going to be based on some of the evidence-based practice. If you see me looking up, I just have some notes on the screen here. So some of the evidence-based past practice in regards to how to make decisions clinically in a lot of different realms. And this one's going to be starting to talk about like the frequency that patients are coming in. So the way that we do evidence-based decision making is based off of 3 criteria. So the first one is the best available evidence, and so that is what research tells us. That's what you can find plenty of resources through the APTA, through JOSPT. There's just so much research out there on different things, and so one piece that we use is the best available evidence. Another thing is the clinician's knowledge and their skills. So what does the clinician have at their fingertips from their education and their training to be able to make the best decision? So some of the topics that I'm going to talk about are not necessarily clinical in nature, and so some of them are a little bit more of that gray area of like, how much does school touch base on these, or how much is my experience in my clinical practice really given me a foundation and model for how to approach this. So that's where these videos are basically just to fill gaps. Some of them are things that some of you are going to listen to and you're going to say, got it, know all that, check, and some of you are going to say like, actually that's helpful framework because I didn't necessarily have a good gauge for how to approach that. So the third thing is patients' wants and needs. And so what is going to fit with meeting the patient where they're at, and is actually going to allow for compliance and improving their quality of life, and again, just kind of meeting them where they're at. So in regards to the frequency that a patient should be coming in, ideally, for almost all patients, we start them off at 2 sessions a week. And so there's no one size fits all and anything like that. But there are some things that I want you to consider when you're thinking of, kind of how long their therapy should last and how often they should be coming in. So, the length of time that you're deciding is based on a bunch of different things. So the extent of the injuries, if the condition's improving with physical therapy, progress with pain relief, if you're seeing improved range of motion, strength, functional improvement, are we meeting goals? And those kind of things are gauges for how often we're going to be seeing a person. When we are using like that foundational game plan from the get-go, we want us to start off with the 2 times a week. Unless it is a very acute injury, then we shift to 3. There are very, very, very few situations that from the get-go and the start, they should be here once a week. So if those are things that you're seeing come up more often, then definitely touch base with me to troubleshoot, because that's definitely not a common occurrence. For what we know, evidence-based practice shows us that they will be able to facilitate more improvement and with the consistency of being here. We also know research also shows us that 70% of patients never complete their plan of care. And so research has shown that if we get them in 2 times a week and help them to buy into the understanding of what we know physiologically, practically, logistically, really does make improvements for them, that will help them to actually get the results that they're looking for. So with that being said, It's going to give us the touch points to be able to properly recommend their treatment program, develop the attainable goals, see if they're meeting them. When they're left to their own devices, it is not what skilled therapy is helpful for. And then they wonder why they're not getting better. And then what that in turn does is it gives PT a bad name in the sense of like, well, PT doesn't work. Well, they weren't utilizing PT as we know it can work. So in the next video, what I want to be able to touch base on is some of the common barriers and just kind of how to talk through some of those common barriers.